Good afternoon and welcome to ICE webinars. Today we are joined by Dr. Chico Parris, breast section lead for Radiology Chartered at Bellin Hospital in Wisconsin. Dr. Parris is a board certified diagnostic breast radiologist, and she earned her medical and graduate dual degrees at the Albert Einstein College of Medicine upon completing the medical scientist training program. She then completed her training in diagnostic radiology at the Norwalk Yale Residency Program in Norwalk, Connecticut, where she ultimately served as chief resident. After graduating from residency, she completed her breast fellowship training at the University of Maryland Medical Center in Baltimore, Maryland. She then served as the medical director for breast imaging at RadNet Murrieta site in Southern California before taking the position as the breast section lead for Radiology Chartered at Bellin Hospital. Her interest includes women's health with a key focus on diagnosing and treating breast cancer. She is essentially passionate about strong doctor-patient connection and communication and creating the most comfortable breast experience possible for her patients. Now, ICE webinars would also like to thank Beakley Medical. Their goal is to help positively impact patient lives and improve clinical outcomes. So if you'd like more information about the product and service they provide to the industry, please visit beakleymedical.com. Now, just a quick reminder to save the date for our 2026 ICE Expo, which will take place at the San Antonio Marriott River Center Hotel in San Antonio, Texas. And that will be February the 20th to the 22nd next year. The Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, radiology technologists, and imaging engineers. ICE offers valuable CE credits from the ASRT and ACI, and is a unique community of key decision makers and influential imaging professionals. For more details, please visit attendice.com. Okay, today's webinar, as usual, is eligible for one ARC Category A CE credit by the AHRA. You can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your one CE credit, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll be wrapping up today's presentation with a live Q&A, so please submit your question anytime using the questions feature on the webinar dashboard. Okay, before we get started, let's kick off today's webinar by giving away one of our ICE gym bags to the attendee that can tell me the answer to the following trivia question. Now, June is Alzheimer's and Brain Awareness Month, so what colour is officially associated with the Alzheimer's Association? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, Dr. Parris is our presenter today, and she will be discussing enhancing patient care by improving interdepartmental communication. So, Dr. Parris, you may begin whenever you're ready.
Very good. Thank you, Linda, for that kind and warm introduction. Good afternoon to the ICE Magazine community, and also to Beakley Medical, our sponsor, who has provided me with this opportunity to present this webinar to you on how to improve patient care through interdepartmental communication. I'd also like to thank everyone who has decided to log on and to attend this webinar. I know that you guys have a very busy schedule in the afternoon, and I appreciate you attending this presentation. So let's get started here. Okay, here we go. My disclosures are I'm a consultant for Beakley Medical and Hologic. The agenda for today will focus on 3 topics. 1, enhancing the patient experience on the day of breast conservation surgery. 2, improving workflow while bridging interdepartmental communication. And 3, decreasing healthcare costs while reducing breast re-excision rates. Now, just a brief history on breast cancer. In 2024, breast cancer was noted as the most common cancer diagnosed in women in the United States, and is the 2nd leading cause of cancer death after lung cancer. Approximately 1 in 8 women will get invasive cancer in their lifetime, and approximately 1 in 800 men will get invasive cancer in their lifetime. So this is not a disease that is just that women are affected by. Men are also affected, but also to a lesser extent. Now, together with lung or colorectal cancer, the second and third most common cancer diagnosis in women, these three diseases account for 52% of all cancers diagnosed in women. And the data from the NIH estimate that over 300,000 women will be diagnosed with breast cancer with a mortality rate of over 42,000 women in 2025. So there are two models when it comes to looking at the natural history of breast cancer. There's the linear-based model, and I'll go into that in a second, and then there's the alternative model. But before we get to that, let's just take a look at this cross-sectional view of the breast. The breast tissue, the fibroglandular tissue, is made up of ducts and lobules, and there is surrounding connective tissue and fat. There is no muscle in the breast. The breast sits on the chest wall and attaches to the pectoralis muscle. Now, if we take a cross-sectional view of one of these ducts, this is what it looks like. It essentially is made up of the outer basement membrane. It has the inner luminal epithelial cell lining and then the more inner layer of the myoepithelial cells. If for some reason we have some type of proliferation of some of the normal myoepithelial cells, this may present as a mass-like or focal asymmetry or distortion on a woman's mammogram. And when it's biopsied, it comes back benign, such as ductal hyperplasia. However, if these cells start to become abnormal, where they may have a change in the nucleus, more than one nucleoli, then when we biopsy, we may get an area of atypia, such as atypical ductal hyperplasia coming from the ducts, or atypical lobular hyperplasia arising from the lobules. If for some reason these abnormal cells fill the entire lumen of that duct, then you may end up with stage 0 breast cancer, referred to as ductal carcinoma in situ, or DCIS. If there's breakthrough the basement membrane, that's when you have that invasive component. And if it disseminates through the vascular or lymphatic system, we can get metastatic disease throughout the body. So when it comes to the linear-based model, it says that you start off in this in situ phase, such as the DCIS, and then some years later, there's an invasive component, and then you get metastatic disease, and then subsequently, this leads to the demise of the patient. But the alternative model says that, the evolution of breast cancer is not in a linear or regular or systematic formation. It can take many different pathways, right? You can start with an invasive cancer, and then it leads to the early demise of the patient. And I'm sure some of us actually know some people who are diagnosed, and within 3 to 6 months, they passed on. Or it can transition to the patient having metastatic disease before it results in death, or it may go to a stagnation phase, or it may go to a regression phase, or it may start off as an in situ cancer and then follow various pathways. So there's no set model when it comes, or there's no set answer as to which pathway breast cancer will transition through. Now, when it comes to cancer screening, the major goals are that we want to find a high percentage of breast cancers in a screening population as measured by the cancer detection rate. And we want to find these cancers within an acceptable range of additional imaging and biopsy with minimum cost. And then we want to find a high percentage of node-negative early stage cancers, which are most likely to be curable. And in my field, this is who we like to utilize, or what we utilize. This is a mammography unit, and that's where everything begins for us, or for me. So when a patient presents to an imaging facility, she may present either for a screening mammogram, which means that she's asymptomatic, or she may present for a diagnostic evaluation. Now let's take a look to see what percentage of patients actually get cleared or will have to return for imaging. If we have 100 women that are being screened, 90% will be told that their mammograms are normal, they are good to return to the general population, and they will return in 1 year. About 10 of these women will be asked to return for additional imaging, such as a mammogram, or mammogram and ultrasound, or straight to an ultrasound. Of those patients that are evaluated, 6 will be told that everything is fine. 2 will be told that, we need to take a closer look at this area, and we need to do a follow-up in 6 months. And usually our follow-ups are done for 2 years, with intervals of 6 months, and then 1 year. And after 2 years, if this finding is stable, then the patient is returned back to the screening population. And of this, 2 out of the 10 will be told that they have a finding in the breast that's indeterminate but suspicious, and we need to do a biopsy. So out of the 100 patients that we saw, 10 were being asked to return for diagnostic imaging. And that's the recall rate that's being requested for us by the American Society of Breast Imaging. We want to have a low recall rate, but still being able to have a high cancer detection rate. Of the patients, out of the 100 patients that we saw, only 2 were requested for a biopsy. And so we have to, explain this to patients because many of them come in, they're very anxious, and we understand that level of anxiety, but they're anxious thinking that something is going to be found and that this is the day that they're going to be told that they have cancer. And as you can see, the majority of our patients end up having a negative screening mammogram. If the patient is not coming for a screening, as stated, they could be coming in for a diagnostic workup. And that's because they have signs and symptoms that are either identified by themselves or by a referring physician during a clinical exam. So this may include lumps or thickening in the breast. It may also include discharge or bleeding. And when it comes to discharge, we're usually concerned about clear or bloody nipple discharge. Many times when patients come in with green or black or some other color, I listen to them, I do the imaging, but my level of suspicion is very low. And at the end, I'm able to convey this to them. Or it could be a change in the size or contour of the breast. There's dimpling of the skin, puckering of the skin, or inversion of the nipple. The nipple is being pulled in because something is there, tethered behind the nipple. Or it could be a change in the color of the areola. Or the breast may end up taking on a hardened presentation. It becomes red. It has pitting to the skin. We call this the peau d'orange, which is kind of like what we see in inflammatory breast carcinoma. The patient, besides coming in diagnostic with symptoms, as stated from the screening study, they can come in diagnostic because the radiologist has recalled them for additional imaging. Now, when the patient comes in for her imaging, the mammogram is obtained. So here's a view of various breast tissue density, because that's the key thing that we have to assess. After we're done looking at all the technical stuff of whether the technologist has done a good job in positioning, we now want to assess the ratio of glandular tissue, which shows up as white, to fat, which shows up as black. Okay, we want to quantitate that, and this tells us the patient's breast tissue density. And that density is broken up into 4 different categories. Category A, which is your fatty fibroglandular tissue, and category B, which is your scattered fibroglandular tissue. These 2 categories make up your non-dense breast. And then you have your category C, which is your heterogeneously dense glandular breast tissue, and category D, your extremely dense glandular breast tissue. And these make up your dense breast tissue. So you can see that when cancer presents as white in the breast on the mammogram, when you have dense glandular breast tissue, this can easily obscure a finding there. And so you have patients who may question, well, if my breast is dense, why do I need to have a mammogram? Well, you have to have the mammogram because other things are being assessed at the same time. We're looking for a little white box called calcifications, which we can only see definitively on a mammogram. And those, usually when suspicious and positive, are usually associated with DCIS, which is the introductal form of the breast cancer. So we want to make sure that we pay special attention to these patients. Patients also ask us, when can we, stop doing our mammograms? And we usually tell them they have to continue doing their mammograms as long as they have more than, 5-year longevity, so to speak. So looking at a mammogram, gives us a lot of information as to what information we can relate to the patient. And this became law in 2024, where the FDA now requires all imaging facilities to inform patients about their breast tissue density. Now, before 2024, we were informing patients who had dense breasts, category C and D, about their breast tissue density. So that's the category D and category C, about their breast tissue density. But as of 2024, September, we now have to even tell the patients who have non-dense breasts about this information because they can now decide what type of supplemental imaging would be needed. And so this movement about breast density notification is not something that just started in 2024, as I stated. Way back in like 2007, 2008, we had our advocate here, Dr. Nancy Capella, who's passed on, who was diagnosed with breast cancer. And she had dense breasts, category D, and she was diagnosed with stage 3 breast cancer. And she decided to advocate to the legislative board there in Connecticut about ways to inform women about their breast tissue density. And so in 2009, Connecticut became the first state to pass the dense breast law, where we actually had to inform patients. And then advocacy, transitioned through the states. In New York, you had Joanne Pushkin, who also pushed for these changes to come to the state of New York. And then it kind of like trickled down. It came to the state of Wisconsin in 2017 when we passed the dense breast law here. And so informing a patient about her breast tissue density is very important. And that's because breast density has been recognized as an independent risk factor for breast cancer. So there are different risks that a patient may have when it comes to, her risk for breast cancer. And having heterogeneously dense breast puts her at a 2 times increased risk, but having extremely dense breast puts her at a 4 times increased risk. So you can see that this risk essentially is even close to if she was diagnosed with atypia within her breast. And so when you stratify the women into the different age group and what percentage of these women have dense breasts, the research has shown that more than 50% of women in their 40s have dense breast tissue. About 37% of women in their 50s have dense breast tissue, and 27% of women in their 60s have dense breast tissue. Now, when we look at it as a function of age again, we see that category 4 here is synonymous with your category D. So that's your extremely dense breast, that's your heterogeneously dense breast, this is your scattered fibroglandular tissue, and 1 is your fatty tissue. But you can see that over the years, as a woman transitions into menopause, that more than 30% of women will continue to have dense breasts. And so it's imperative that we inform these women of their breast tissue density because of the risk that small cancers may be obscured or missed because of the dense breast tissue, and supplemental imaging is key for these patients. These supplemental imagings may exist in forms of doing screening breast ultrasounds or breast MRIs or contrast-enhanced mammography. The breast MRIs and the contrast-enhanced mammography are your vascular-based imaging study compared to the ultrasound. So let's just take a look at this quick case. This is like a typical run-through of my day in the facility. I have a symptomatic 79-year-old female, and she's presenting with new pain to the inferior quadrant of her left breast. Okay, so she's diagnostic. And so this patient has scattered fibroglandular breast tissue. The findings we see here in the right breast have been stable on her prior mammograms. Within the left breast, though, in the mid-depth, upper outer quadrant, we see that there's, I had the priors, so we saw that there was a new irregular spiculated mass. And so spot compression views were obtained, and you can see there's persistence of this mass, which has very ill-defined or spiculated margins, which we'll identify when she had her ultrasound. So this is the ultrasound where we see this mass right here. And so you can see the angulated margins of it. We want to find cancers that are less than 10 millimeters. That's where we're very effective, finding these things when they're small. And we can see here that there is proliferation of the, not proliferation, but flow within the surrounding vascular tissue. We always image the axilla to make sure that there is no lymph nodes that have been shown to have any type of abnormality to them, because we always want to assess extent of disease into the lymphatic system. So this patient had her biopsy, and you can see this is the clip that we're placing here. We always do a post-mammogram. This is key, this is vital. What happens there? We are able to cross-correlate what was seen on the original mammogram. Then we found a sonographic correlate that we thought, this looks like the thing on the mammogram. But when we biopsy, we leave the clip, we verify definitively that we have identified the target and we've targeted the area correctly. And so the patient goes on to pathology for that tissue to be assessed. And this pathology finding was of invasive ductal carcinoma grade 2, and it had associated DCIS. We always do receptor status, receptor assessment to find for the ER, PR, HER2/neu, but we also look at the Ki-67 because that tells us how rapidly growing our cancer is. And so here on the pathology slide, this is an H&E staining. You can see that this is a duct where many of the abnormal cells are still contained within it, and this is the DCIS component. And here you can see you have disruption of those ducts and extension of disease out of the ducts into the connective tissue, and this is more here of the invasive component. So then this patient here, she, through her discussion with her surgeon, she chooses to have a lumpectomy. We place the localization device, and then we have our specimen radiograph. And using the specimen radiograph, where we have these MarginMap charms, we're able to easily identify and quickly tell our surgeon whether she's got the mass, the residual mass, the clip, the localization device, and whether she has enough normal tissue around for us to say clear margins. And this is all done before that specimen goes to the pathologist. So essentially, when our patients meet with our surgeons, the surgical options that are available to her are she can choose to do nothing. And you have to respect that as long as you've given her all of the any pertinent information for her to make this decision. She can choose to have a mastectomy, or she can choose to have breast conservation surgery or a lumpectomy. And so essentially the breast conservation surgery is when the surgeon goes back and removes all additional cancerous cells, that tumor, because remember, all we did was biopsy or sample the mass that was there. It was not removed. So they go back and they're going to remove all abnormal cells, and they're going to take some of that normal breast tissue around because we want to make sure that we have clear margins. Now, breast conservation surgery accounts for approximately 65% of all operations for breast cancer. And one of the unavoidable consequences of breast conservation surgery is that a subset of women will return to have reoperation or re-excision, so to speak, because they have positive margins. The literature has shown that when it comes to re-excision, there's a high range or a wide range. It ranges between 20 and 30%. And at some institutions, it can go as high as 60%. You don't want that. You don't want to be taking back more than half of your patients to surgery. So optimizing the re-excision rates for breast conservation surgery is critical on both the patient level and the system level. So let's take a look at how we would want to enhance the patient experience on the day of breast conservation surgery. You want to do it like this. This is me. Right here I am on my African trip, and I'm doing a cheetah walk tour here in Zimbabwe. And I'm trying to remain nice and calm while my handlers are somewhere around. And this is what we want for a patient. We want to make sure that we provide them with so much information so that on the day that she comes in for surgery and she's being prepped, that her anxiety levels have been decreased. We have addressed many of her needs, such as her preoperative anxiety, her psychological needs, some type of support and comfort before, during, and after surgery. And all of this is to help optimize the surgical experience. So let's take a look at the right side of the screen where we focus on the anxiety. Now, how do we help to lower patients' anxiety? They have a lot of questions. They are thinking about, their life and, how it could potentially be altered with this new diagnosis. There are times when patients come in for their biopsies. I'm more than happy to give them Valium, which helps to, decrease the anxiety. But that is a minimally, invasive procedure that I'm performing. If we decide to take a look at some of the pharmacological treatments that patients could be given, these can have some type of adverse effects for the patient, for the day of the surgery, breathing problems, drowsiness, interfering with anesthetic drugs, or even prolong the recovery phase for that patient. There's been a big push, which Wang and others address, to looking at non-pharmacological interventions. And these will include, cognitive behavioral therapy, like addressing some of the patient's distorted thoughts that they may have and trying to correct that. We can use music therapy. We actually use that when we're doing our biopsies. We ask the patient, what genre of music do you listen to? And so that's for her to just get out of her head and just to calm herself down. Some patients benefit from preoperative preparation videos. It's very sensory for them, right? And so they want to see exactly what happens when I walk into the facility that day for my surgery, what happens, in pre-op, what happens when I'm taking the surgery, what happens after surgery. Just seeing a video of someone going through it and what they could possibly experience actually helps them. So you can also do aromatherapy, right? Some of that, using the senses in that way can actually help patients to calm down. Some patients actually need to be hypnotized, and it actually works for them. You have other image-guided relaxation therapy, and maybe it's just as simple as giving the patient a massage. Who won't want a massage? I want one right now, right? It's just anything that helps you to relax. And so This is what you want to provide to your patient. This helps to decrease their anxiety. And so shifting to the non-pharmacological intervention might be of benefit over the pharmaceutical use of drugs. Now, in addressing the psychological needs, procedural information, we stated that before, walking through the patients, all the information that they would need, maybe giving it to them before so they can take it home and read it by themselves or with someone they trust. Sensory information, addressing what they would see, behavioral instruction, what they should and should not, be doing, cognitive intervention, relaxation techniques, hypnosis, and then the emotion-focused interventions. Now, what about things about, supporting them and making sure they have a comfortable environment before and after surgery? Well, we can focus on the pre-op preparation, as stated, giving them, information. And you want to give this maybe, yes, both in electronic and paper form, right? Because every patient may not have access to electronic devices where they can look at this information. You want to discuss post-surgical physical changes to the breast. This is key, right? I mean, a woman has been with her body for X years, and all of a sudden it gets altered. And this can be, this can affect her mentally, right? So you want to make sure you walk her through about the swelling and when she'll have to come back in for you to check about that, what she should be seeing, if there are drains that are placed there, when she should know if something is right or wrong. All that information needs to be discussed with the patient. You want to make sure she has proper post-surgical garments, right? When she's leaving the facility, you don't want her to have to struggle to put her arms through a sweater or something, depending on the time of the year that she's there for her surgery. Comfortable post-surgical sleep. Supportive pillows. Is this something that could be provided by the hospital facility? To patient care? Is it something that the patient can pick up in the store? A recliner chair. Maybe this will help the patient to sleep in a position on her back because she's not accustomed sleeping that way. That way pressure is not placed on the surgical site. Proper posture. Once again, comfortable clothing, but then again, pain management. We want to address the patient's pain. You can't assume that what worked for one patient will translate and work for another. So you want to make sure that if she's in pain, that she has medication that she has access to use. Now, minimizing strain on the body, helping with daily tasks. So meal preparations, maybe having a discussion with a patient of someone coming into the home to prepare her meals. But what if that's not possible? Then maybe go through having a meal prep prior where she sets aside dishes for the whole week before her surgery. Someone to be there to help her with mobility issues if there are issues. And self-care. I mean, just simple things such as, combing her hair and she may not be able to raise her hands above her shoulder, or, doing her nails, just some normal things. However, while, we're pushing for the patient to rest, we have to make sure that there's some type of physical activity. We don't want her to just, be sitting in a chair all day. In addition, post-care, we have to address certain things such as transportation. Not just arriving to the facility, but is there someone there to take the patient home after surgery? And is it that person or someone else who could be with that person within the first 24 hours of surgery? And that's because of the anesthesia that the patient may that the patient will be still under, right? It could affect some patients more than others where there's a longer period of time before they fully come out of that. Once again, preparing meals, mobility issues. But then here's another thing addressed in the paper by Carr. You want to make sure you give patients precise surgical instructions on their physical activities. Maybe refraining from vigorous activity for 6 weeks. Restrict excessive use of arms for at least 5 to 7 days. No lifting above the head for 2 weeks. So, she now has to maybe pick out certain clothing that she can easily slip her arm to, so she doesn't have to raise her hands above her head. Refrain from physical contact with the breast for 6 weeks. This is important, right? Because this is not only for the patient. Patients have, a spouse or significant others, and they may be trying to figure out, well, when can we go back to some level of normalcy as we move through your post-care? Once again, we want to address pain management. Always make sure that the patient's pain is being addressed. Now, we're doing all of this, but we have to remember something that is of importance. May not be for those taking care of the patient, but it is for the patient. And that is looking at the costs associated with performing breast conservation surgery. In several papers that Greenup wrote about, the cost of care is important for women, especially when it comes to lower incomes. Less than a quarter of patients in this study had reported that the cost of care was discussed with them, with the medical team. So 22% reported that it was discussed. Now there's 78% of women who did not have this discussion. And so we need to change that dynamic. For some women, the cost of care they found was higher than expected. And a few even reported that the unexpected financial burden interfered with subsequent medical care. So they may have had to change whether they got certain medications for some other disease process they had. Some women reported depleting their savings or having to borrow from family and friends just to pay for treatment. We don't want this for our women, right? 1/3 of women with the lowest income said they had difficulty affording basic necessities as a result. Now, although I'm framing it this way, I have to tell you that there's a limitation, okay? And it doesn't necessarily fall on the surgeons who did not do a good job, or the oncologists, or the radiation oncologist. I'm a physician, and I will tell you right now that I was not trained to have a conversation with my patients about, of her finances when it comes to getting a mammogram or an ultrasound, or even when she has to go to surgery, right? And a majority of doctors are not trained on this. We are trained on how to deliver bad news to patient, how to have empathy with our patients, how to, speak and acknowledge our patients and make sure that we're listening to her along those lines, because we want our patients to know that we hear them. But at no point am I told to discuss finances with them. And so for the surgeons, because they're the point person with the patient, there's difficulty in trying to estimate what the out-of-pocket cost would be for their individual patients as different types of treatment or management are being tailored. So there's some difficulty there. So what is needed? We need to have financial navigators at our facilities. So we have one at ours, and if you don't have one at yours, you need to get that, because that's how you get to help patients. You want to create transparency so that they are aware of what things cost and how this may affect what they choose to have, right? They may choose upfront to go ahead with something that would just, say, okay, I don't have to worry about this problem anymore, right? Forget about a lumpectomy, I'm going to choose a mastectomy. They're able to choose that. And then we have to inform women about the Women's Health and Cancer Rights Act of 1998, right? Obviously, it depends on the type of insurance a woman has, but it mandates that insurance companies or these insurance plans, they cover the stages of breast reconstruction, whether it be for a mastectomy or a lumpectomy. So we want to leave our patients, like this giraffe that I encountered on the safari at the Kapana River Lodge, right? We just happened upon this giraffe just like sitting there as though nothing is going on. And what you know about the history of giraffes is that they get a moment of grace or rest for about 20 minutes to 2 hours, because they have to be on a constant move because of their predators. And so when we have our patients, as we're preparing them for surgery and we're taking them through this entire process, we want them to have this moment of grace and just to be nice and calm. So let's look at improving workflow while bridging interdepartmental communication. So when a patient presents to the imaging center, she may go through imaging, radiology. And after her workup or assessment, this may lead to her having samples being sent to the pathologist. And if it comes back positive, high risk or malignancy, she then interacts with the surgeon. After that, she may then meet the radiation oncology team or the oncology team. Okay? Or the patient may come right in and go through surgery. And the surgeon, he or she may do the biopsy, send that tissue to the pathologist. Or the surgeon may refer the patient to the radiology imaging team. So if we look at a flow of information within radiology, and this can be applied to breast and non-breast imaging, essentially it's an interplay and a communication loop that has to remain constantly closed as we interact with the patient and the referring clinician. We have to make sure that we're all getting the answers that we need. So the clinician may send the patient in with a clinical question. Let's just say it's breast. This is a screening patient. Does she have disease or not? Or they may say, this patient is symptomatic. Is there something there that we should be concerned with? So we get the requisition for the study, all the patient history, we do the imaging, and then the imaging could be interpreted by the radiologist, and that's a screening mammogram, nothing is seen, right? That's 90% of our patients, they get to go home. Or something is seen, that's the 10% of our patients, and this would lead to further diagnostic workup. And this workup will be where we do imaging, where we then speak to the patient after. I usually back scan with my technologist, and that way I can tell the patients and show the patients the finding and let them know why I'm recommending the BioRaz I'm recommending and what this would mean for her. This can then lead to her having to meet with other many out of my clinical colleagues, such as surgery, radiation oncology, and oncology. And then at times, based on the pathology, there's a multidisciplinary committee that meets. And so that's like a tumor board where we discuss the patient's results and what's the best treatment plan for the patient. So let's just say that this patient comes through the imaging department. Here we have our beautiful technologist taking a mammogram. Images are obtained. The radiologist is assessing the imaging. And so the radiologist could be looking at a mass such as this and say, well circumscribed, likely it's going to be benign. Let's see what ultrasound shows. Or they could already have their level of suspicion that this is likely cancer based on seeing this hyperdense speculated mass. So I'm going to take you to another case. This is for a patient who has heterogeneously dense glandular breast tissue. And here we have another small cancer. Once again, I'm going to stress, I'm not going to be showing you any large masses. Why? By then the patient might be coming in diagnostic. She's symptomatic. She has felt it or the doctor has felt it. I want to show you those small masses, which shows the power of mammography and the radiologist reading the imaging study. Those two put together, we want to find these cancers when they're 10 millimeters or less, because that's when we have the greatest impact on the patient's outcome. And so it's a speculated mass. We see here when we do spot compression views that there are microcalcifications associated with the mass. And so this patient goes on to have her ultrasound. Irregular hyperpoic mass, is avascular. Once again, we scan the axilla looking for lymph nodes. There are no abnormal lymph nodes, just normal lymph nodes are visualized. So the patient has her biopsy and we leave her clip. We always want to tag that tissue, okay? Because what if we have to go back to the area to help the surgeon to remove it? And then for this patient, we obtain what's called a specimen radiograph of the cores, and we actually can see calcifications that are present. And we actually point this out, and we'll send this off to the pathologist so that they can have this access, and they can see what cores have calcifications. And so for this patient, her diagnosis was invasive ductal carcinoma, but she was of a grade 3, so a higher grade. And she had ductal carcinoma in situ, but it was high grade. And her receptor status shows that she had a very high Ki67. So this was a rapidly growing cancer that was present there. You can see how disorganized many of the ducts have become as there is invasion into the connective tissue. So the patient meets with a surgeon, and that's when our surgeon, has that detailed discussion with them. They're going to talk about the cancer type. They're going to talk about whether it's coming or arising from the ducts, or is it coming from the lobular units. They're going to talk about the grade of that cancer, and they're going to look at the proliferation rate. How rapidly is it dividing? Is it a localized disease, localized to the breast, or is it metastasized on elsewhere? Is it focal, as in one spot within the breast, or is it multifocal, which means more than one spot, but they're still localized to the same quadrant? Or is it multicentric, where you have more than one spot and they're in different areas of the breast? This all makes a difference as to what type of treatment this patient is likely to receive. Treatment options include, like I stated, watching and doing nothing. Or the patient may have to choose, between doing a lumpectomy with or without radiation and chemo, or mastectomy with and without radiation and chemo, and plus or minus reconstructive surgery. Does she want a tram flap reconstructive surgery? Does she want implants? All those things are discussed. And so then the patient is given referrals. And these referrals are not only to the oncology and radiation oncology team or plastic surgery, she's going to do the reconstructive surgery, but you've got to remember that we've got to refer our patients who are younger than 50 to the OBGYN. And this is because these patients may still be thinking about expanding their family or even starting their family if this woman is diagnosed in her early 30s. And so you have to listen to your patient. That's the key thing, because all of this information is coming at them. And they might be thinking, oh, hold on, take a step back. I want to go ahead and do something that's more natural. And they might choose to go the holistic route. And you have to respect that, right? And then you have to say to them, I'm going to give you all this information. You can come back to us when you're ready to continue with your care, but you want to respect the choices that they make. And so then she goes on to see the radiation oncology, and that's when they're using these high energy X-ray photons to, target these cancer cells. And the radiation treatment may be in the form of internal radiation, which is your IORT or intraoperative radiation therapy. And for patients to have this, they have to fit a certain criteria. Certain age, size of the tumor, how far it is from the chest wall and the nipple, all of that. That's done by the radiation oncologist. Or they may have, or it be recommended that they have external radiation therapy. And that can be given to them after their lumpectomy, and then they have to decide if it's going to be the entire breast that's radiated or part of the breast, or if they're going to have it after their mastectomy. They may have to also transition onto the oncology team, and that's when we use the chemotherapeutic agents to target any residual cells within the breast or elsewhere in the body. And they may choose to have, or it is discussed with them that they have neoadjuvant chemotherapy, which is chemotherapy before surgery. And that's usually done to help decrease the burden of disease. Or they may have adjunct therapy, which may be they get hormonal or endocrine therapy or systemic chemotherapy. So when we talk about workflow, we are talking more of the communication, which is key and vital between these departments, because we are transitioning information from each of these departments, and we all have to make sure that we're on board, okay? So it starts with the radiologist, if that's where the patient came through the system. You wanna make sure that you're using imaging to identify your cancer, and you wanna be imaging that's up to date, okay? Right now, 3D mammography is what is advocated for us to use when we do our mammographic imaging. So for instance, if you're at a facility using 2D imaging, you want to ask yourself, what are some of the limitations that I am encountering, and how can I give my patients something that has been shown to be better at identifying cancers. When you do your diagnostic workup and biopsy, you want to make sure that that's done in a timely manner. You don't want to make sure that there's this lapse in the patient's care, where due to having a backlog, the patient is not able to come into the facility in a timely manner for the diagnostic workup, and when that's done, getting her scheduled for a biopsy. Your reports, you want to make sure that your report is succinct about your findings, especially about the size of the mass, because that information will also be used to help stage the cancer. Also looking at the extent of disease. Do you see any other disease within the breast or the contralateral breast, and has it gone to the axilla? The pathologists, they're paying attention to giving us improve accuracy in the diagnosis using the proper staining techniques and analysis. Our surgeons, as we stated earlier, they're the ones doing that more in-depth discussion with the patient about her treatment options. The radiation therapist, is radiation needed? That's what you discuss with the patient, because she may not want it, right? And if radiation will be given, is it internal or external? And then for how long? And you want to take all of this into consideration because, our patients have lives, right? And this then leads to a change in that. First, we've got to find out, does the patient have transportation to come in for her radiation? Because the radiation may be over several weeks, maybe 4 to 5 weeks, about 25 to 30 treatments, and she now has to come in for that. And how does that affect her job, her income, her finances? So all of that has to be discussed with her. The oncologist, they're giving her treatment options that would aid in increasing the survival of the patient and decreasing her risk of reoccurrence. So when we work, we want to work together. These are some impalas here at the Chobe National Park. We don't want to be fighting and butting heads, right? Because we all have a common goal. We want to take care of the patient and give her the best treatment possible. So we want to try to be like these chamka, that's how you pronounce it, chamka baboons. These are in a troop, right? We see that we're all at different stages. The mom is taking care of the baby, the dad is taking care of the mom. Same thing, okay? Together we want to work as a team to help take care of our patients. So let's take a look now at decreasing the healthcare costs while reducing breast re-excision rates. So as stated, 65% of all operations for breast cancer are or pertain to breast conservation surgery. And we already stated that a subset of women will have positive margins. And having these positive margins will require reoperation, and it's something that is unavoidable. The literature reports that the breast conservation surgery re-excision rate can range anywhere between 20 and 30%. And the American Society of Breast Surgeons, they have a metric or goal set for having a re-excision rate of 10%. But it's not just in the American system. The European Society of Cancer Specialists also have put out that they would like to have that goal of 10% or less re-excision rate. So optimizing re-excision rates after breast conservation surgery is critical at the patient and systems level. For the patient, reoperation after breast conservation surgery usually results in additional time away from work. And then there's this added mental and physical stress to our patient. Did I make the right decision? Should I have just removed my breast? Now I have to go back for, another surgery. What does this do with time away from work or my family? Right? It can also result in a delay of further care, right? Because based on the burden of disease, neoadjuvant chemotherapy was going to be initiated. But now we cannot do that, or radiation therapy, right? And so system-wise, reoperation results in increased medical costs. Improvements in rates translate to significant savings to the healthcare system. Now, there are risks associated with breast conservation surgery. Um, you know, every surgery has its risk. So these usually include the same: infections, possibility of infections, hematoma, seroma cavity, areas of fat necrosis. But when a patient has to go back for, re-excision surgery, this can lead to prolonged post-operative pain. There could be increased scarring at the re-excision site. She may end up with having an inferior cosmetic outcome or even decreased morbidity. And so Metcalf, in their paper, they found that women undergoing repeated surgery or re-excision surgery to achieve clear margins after a lumpectomy have a 47.6% higher risk of at least one complication, and then an 89.1% risk of multiple complications compared with patients undergoing only a single lumpectomy. And so we don't want that for our patients, right? And it's shown that at 3 months following a lumpectomy, the complications are twice as likely for patients than having a repeated breast surgery. So the complication rate goes up the more the patient has to be taken back to surgery. So we want to make sure that we come up with tools that are effective so that the patient goes to surgery just once. So this is a study out of Canada, British Columbia, and what the group was trying to assess was the reoperation costs in attempted breast conservation surgery. Now, there isn't a lot of information out there about the cost of surgery in general, right? Because it permeates, right? Or even about breast conservation surgery. And so with this paper, this is the decision tree model that they came up with. They said, if a patient has her initial breast conservation surgery, after that surgery, she could be told one of two things. She needs no further surgery, all is well, all margins are clear, or that there's positive margins and she has to go for reoperation. And she may go for reoperation and then later on still have to end up with a mastectomy or a second breast conservation surgery. And she may go through these permutations based on what is seen. And so we don't want that. We are trying to limit our patients. We want all of our patients essentially to transition to going to no further surgery. And so we want to come up with tools and products that would lead along that pathway and decrease this reoperation rate. And so the cost that they found, this is now published in 2016, and this is Canadian dollars, right? So the costs that they found were associated with both professional fees and the hospital fees. And together, this equaled about $3,443. And that was the lower end of the cost compared to when the patient would have to add on radiation therapy after her breast conservation surgery, or if she decided that she was just going to go have a mastectomy and then it's with or without reconstruction. And so what they gathered from their research was coming up with something that was key. They said, if we take the average re-excision rate or average reoperation rate. Now we said it ranged between 20 and 30%, right? They said, let's choose that the reoperation rate is 23%. The mean cost for patients would be about $10,000. If we decide to get to our target of 10% or lower reoperation rate, the cost would work out to be about $9,000 per patient. And then this would translate to be about a $1,000 saving for our patients, but to the population at whole, when extrapolated, about 1.9 million. But another way to look at this data, they said, was this could actually be a potential savings that we can get. $8,118 could be saved if this reoperation is avoided. Okay, and that's the key thing. If we can lower this reoperation rate close to 0%, it would be a cost-saving measure for the patient and to the system. So how do we get to re-excision and the radiologist being involved? Well, specimens are usually prepared for analysis for excision, and it can be done through many different ways. One of them is an inking process. And with the inking process, usually the radiologist is excluded because we can't image a specimen that has ink, right? So this is a crosstalk here only between the surgeon and the pathologist. Or you can use the surgical clip method. And in this method, one clip denotes a particular margin, two clips another, and three clips another. And here, the radiologist is involved, but it can become, kind of like frustrating. Why? You constantly have to remember which margin is associated with which number of clips, okay? And then sometimes these clips can overlap, and this will then lead to having the tech go back to do repeat imaging, which delays time in us getting to put in that call to the OR to let the surgeon know about the margins. So here is this lesion here, it's a wire localization, and here your clips didn't know the margins, but there are no clips over here for this margin. This is a gross specimen where they're using the string method. And in the string method, it states that you're going to cut one of the strings short, and that's going to be short equals superior, and you're going to cut one of the strings long, and L is going to be equal to the lateral margin. And so here's a specimen radiograph of that, but you can see visibility of the string is very limited. And in fact, here it is blown up here. You have the string, but let's make that bigger for you. So here are the strings, right? And so this string here would denotate the long string, and this string would be the short, because I can see part of this is still here, but this goes out to the end of the margin here. But I encountered when I started, many of the strings, all of them terminate into the edge of the specimen. And so the technologist will constantly have to go back to retake that image. We're told not to touch the specimen, so we're trying to shift it over so we can see those strings. And I would be making calls to the OR when I got to my new facility, having to use this method, and I was in a panic, I would have to tell you. And for those of you who know me, I do not like to be in a state of panic. I'm calling the OR and I'm trying to guess and try to estimate where we are so I can tell them now which margins are close. But what was frustrating was, also having to then say, okay, this is my short, S means superior, so this is inferior, this is lateral. I had to do too much of that. I wanted a tool that was going to be just effective and straightforward. And so prior to coming to the facility, I was using these MarginMap charms. And I felt that they were very simple. You had 6 charms. They were cranial, caudal, medial, deep, lateral, and skin. And you attached them to the specimen. The surgeon did, not me. And you only had to attach a minimum of 4 of them. But it was very easy to just look at that and read very quickly that cranial, lateral, caudal, medial, and I can actually tell the surgeon, I have the mass, I have the clip, and I have the localization device. I have enough normal tissue around for it to be clear margins. Okay? And so this led to, me speaking to my lead surgeon. I approached her and I said, I'm having some difficulty. My level of confidence has gone down. I feel like I'm not able to talk to you in the OR with some level of confidence, because then I have to take that specimen and, I'm looking at the patient's mammogram and I'm trying to put the two together. Sometimes there's a lag. It takes a while for me to adjust, versus if I just have these charms that I can actually put on, I can quickly delineate where I am, because as radiologists, that's how we read, right? We read and we say whether things are cranial caudal, whether things are medial or lateral on the CC projection, right? Having the string was introducing a different type of language that I would have to learn. And so she says, well, tell me more about, these charms that you'd like to introduce. Let's see what we can do. And essentially what I had to do was I had to find out what the facility and surgeon's re-excision rate was. And I essentially came up with a sketch or drawing to show what we could achieve, essentially. And so if the re-excision rate was greater than 10%, we would go along this pathway, versus if it was less than 10%, we'd transition to this pathway. I looked at the current methods that were being used, and we were using the string method, and I wanted to transition them to the charms method. So I had to look to see what was the interdepartmental communication like. Did it involve the radiologist with a surgeon? Did it involve the surgeon using a faxitron? Now, when I spoke to many of my colleagues, and I would ask them, like, are you guys having any problems with this? And speaking to the surgeon, their response at that time was that we just tell them that they have the lesion, the clip, and the RFID. They're not really there to tell the surgeon about margins and all of that. And I felt that that was a limitation. My job in real time while the surgeon was in the OR was to give him or her as much information as possible that they could use to help provide better care to the patient. So in real time, if I can tell them to remove additional tissue and so they can send it to the pathologist, and then the pathologist will say all margins are clear, that's much better than her having to have an uncomfortable conversation with the patient saying that we have to go back to surgery. So I looked at this, I then looked at the scientific data that was out there, information, I gathered all of that, and then I did an interdepartmental presentation. And we'll start with our pathologists because they were just like, as long as whatever you're doing is not adding any type of new stains or inks or dyes to the specimen, we're good. Great. Radiology team was just whatever you can do that would help to improve this, great, right? Because they were not reporting on the margins. And then for the surgical team, my lead surgeon was on board. She was excited to actually try this out. Could this be something that will help to decrease the re-excision rate? And then we had to then convince the surgical team that are usually involved, which are like your surgical techs and the scrub nurses, because they were concerned about transitioning from this method that they knew for a number of years to a new method, and they would have to account for like new items on the surgical field and having to make sure that's cleared and how all of this change was going to happen, right? But then, we got the results when we did a pilot study, and it showed that this was actually helping the surgeons without impeding the surgical team, the radiologist, or the pathologist, and we were able to move on. But what do you want to know? You want to know what my surgical team re-excision rate was. Well, it was less than 10%. It was actually 6.2. But I was not afraid because I still wanted to have something that would improve my level of confidence. And I said, is there room for improvement? And could this lead to better patient care and a savings for the hospital system? My prior surgeon that I worked with had a less than 2% re-excision rate. And I said, I want to try to see if I can get us there. And so my surgeon was excited. So we did what's called a PQI project, or practice quality improvement, and we had to essentially present this to the hospital steering committee because any new products that are being brought into the hospital, it has to be approved. And so we said we wanted to utilize the MarginMap Specimen Orientation Charms to accurately mark the margins of specimens that have cancers during breast conservation surgery in real time while our surgeon was in the operating room, and that we want to take the re-excision rate from 6.2% to like 3% or even less if we could get that. They gave us a period of time to do it for this pilot study. It was done between May and December. And our objectives were that we wanted to decrease the costs associated with the OR time, right? Because having to go back for re-excision leads to you using more of the surgical supplies that are there. So we want to decrease that. We want to decrease the cost to the patients for having to go back for re-excision because sometimes cost is not financial, it's time away from our family, okay? We want to give the surgeons more time to spend in the clinic and on other surgical cases. Maybe they have a backlog. Maybe we can help to move that along. And we want to increase the confidence and ease of assessment by the radiologist and the pathology team. So I'm just going to show you a few images that we obtained. Here are the masses that we have. We did our biopsy, there's a clip, and then the patient goes on for her lumpectomy. Right away, I can tell that, the margins are clear. And I'm sure you guys can. Like right now, I'm sure you guys can actually use these MarginMap charms and figure out what margins are cleared. Here we have another mass. Right then and there. What are you guys going to all say? Medial margin, right? Raise your hand, shout it out. Medial margin. Tell the surgeon that we have cancer extending there. Very easy to use. Here we have some classifications. Okay, and then we have our marker place. And in this case, you can see that we have the classifications that are close. And my technologist in real time did some rotation views of the specimen. And she came in and she told me, yup, you're going to have to tell the surgeon too close to the cranial margin. So this increased the communication not only between the radiologist and the surgeon, but also within the mammography department for a technologist. And in this case here that I'm showing, you're going to see that the radiologist at that time, couldn't see any classifications, saw some post-biopsy changes, and decided that they're going to measure and figure out how close they were. And they said that everything was negative, but really it came back that the caudal margin was positive. So you don't want to do that. This was a learning case for us to say that we want to make sure that we have enough normal tissue extended around the mass. So the breast conservation surgery re-excision rate, when we compared it to the national average, the surgeons, before they used the MarginMap markers, they were 6.2%, but after utilization of the markers, you can see it dropped to almost 3.2%. And so the average cost of re-excision, that was also decreased from 60,000 to about 30,000. And in the cost analysis that we did, looking at the yearly lumpectomies, we have 130 that were usually done with the average cost of 7,500, and they usually did about 8 lumpectomies a year. That cost there usually was around 60,000. The re-excision, after we introduced the MarginMap, within that short period of time went down to 4 re-excision at a cost of 30,000. So there was a savings of 30,000, but by the time you take away the cost for paying for the charms, it was a total saving of 27,000. So in conclusion, there's a decrease in the number of lumpectomies being performed. Breast conservation surgery accounts for 65% of all breast surgeries. Having a strong connection between the radiology, surgery, and pathology departments have been instrumental in delivering optimal patient care. Facilities with a decreased re-excision rate of 10% or less are achieving the requested metrics set by the American Society of Breast Surgeons while delivering care that results in decreased reoperations and complications. The MarginMap Specimen Orientation Charms that we have used have helped to decrease the re-excision rates, which resulted in better patient care, a stronger bond between the radiology, pathology, and surgical teams, and cost-saving measures at our facility at Bellin Health. There's a shallow learning curve that's there between the radiology team, the pathology team, and the surgical team. And so we were able to actually identify a tool that was able to be more effective in delivering better care to the patient, increasing our interdepartmental strengths that we had, and lowering or putting us a cost-saving measure to the system. So like our family here on this trip, we want to always look for new adventures and new initiatives at your facility. If there's something that you can look at that will help to improve patient care, try to explore it. Try to see who you need to speak to try to get it started. Because we want to enjoy many sunsets, but we want to also make sure that we extend this grace to our patients and we deliver the best type of patient care to them so that they have many more of these. I'd like to say thank you right out of Green Bay, Wisconsin here at the Bellin Health Gunderson System. I'd like to thank many of the administrators at my facility who worked with me, the techs, the surgeons, as I try to push various initiatives there. Thank you once again to ICE Magazine and Weekly Medical for sponsoring this, and to my group that I work with, Radiology Chartered. Thank you very much.
Perfect. Thank you so much. We've got time to squeeze one quick question in. When you have a change to best practices, how do you communicate that?
Yeah, exactly. So when you want to do that, this is something you should try to meet with those individuals who this will affect. And so for me, it was pathology, surgery, and the radiology group. And then you want to get these administrators, all of them together. And if you have to do a presentation to walk them through the initiative that you'd like to implement, to show them the effective change that it would have, that is what you need to do. But everyone needs to meet in a room so that we can actually figure out the common goal or cause of that initiative that you're trying to implement.
Perfect. Thank you so much, Dr. Parris, for your time today and such a great presentation. Thank you also to Weekly Medical. Please visit weeklymedical.com for more information about that. Now, if you have any further questions for Dr. Parris, please email me at webinar@MD Publishing and I will be happy to forward them to her. Now, as promised, the answer to today's trivia question is purple, so congratulations to our winner, Nicole Richmond in Indiana. And just a quick reminder, you can obtain your C certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. Now, you must complete the survey to receive your 1 ARC Category A CE credit by the AHRA, and you'll be able to download the certificate directly from your computer once the survey is submitted. Now, if you have any questions, you can reach us again at webinar@mdpublishing.com. Please visit icewebinars.live for more details of all our upcoming ICE webinars and, of course, complimentary registration. Now, if you've missed any of our past ICE webinars, again, visit icewebinars.live to view our whole webinar archive. So thank you once again for your time today, and I hope you all enjoy the rest of your day.